Hi, and welcome to the Vet Dental Show. I'm Brett Beckman, board certified veterinary dentist, and we do this podcast every Wednesday for you, the technicians and veterinarians in general practice, to give you insights and actionable steps that make your dentistry service even better. If you have not already, the International Veterinary Dentistry Institute is sponsoring a live seminar, online training, July 17th, and you're invited. Register at ivdi.org/July, and we'll see you there. So let's go ahead and get started with our cases. And the first question is, I've noticed that you do a lot of envelope flaps, and I saw one in a case during canine extraction. I assume that the gingiva reattaches to the teeth that are not extracted. How long does it take to reattach? So what Aaron's referring to is the maxillary and mandibular canine extraction, where we go into the gingiva adjacent to the tooth at the sulcus. So we take that scalpel, go back in the pocket or the sulcus of the tooth and start our flap there without making an incision. And then once we finish the extraction of the canine, then that is sutured between the teeth, opposing the attached gingiva back to the bone. And Aaron, to answer your question, it literally takes days for that to reattach, and there's no chance, or the only chance of that not reattaching is if the patient gets to the surgical site, and in that case you're going to get dehiscence. And if that happens, it's probably because of too much tension on the flap, or it's because the patient got to it. So we like to have a cone Elizabethan collar on all of the extractions that we do, especially rostral extractions, especially canines, and that prevents any possibility that that will be a problem. So great question, Aaron. Thanks for that. Kristen has a question. What is the risk of iatrogenic jaw fracture during extraction in the canine patient? And that that's a great question, and let me go to the keynote and I'll show you what we're talking about, and I'll describe it for our podcast listeners. So when we have a lucency adjacent to the apex of the tooth, then oftentimes that lucency is like you see in this image, where describing this, the roots of the canine tooth are not really that close at all to the ventral cortex of the mandible. And it would take a tremendous lucency to extend to that point with the roots that far away from the ventral cortex. And even then, sometimes there's enough bone stability there that it's not going to be a problem. In this case, let's say it does extend to the cortex. You've got a lucency around the mesial root. It's not that big, but it's pretty dense. It extends to the cortex and breaks through the cortex somewhere, but there's no bone loss down to that. And the reason why that tooth has the lucency is because it was compromised endodontically, or either through open fracture or through trauma and chronic pulpitis. And with that lucency and with those tooth roots being that far away and no bone loss, there's almost no chance of fracture of that mandible if you know how to do the correct technique. So that's the answer to that question from that standpoint. But if there's bone loss that surrounds that entire two-root structure there, from the standpoint of all the way to the apex, and those root apices are closer to the ventral cortex of the mandible, which happens in small dogs, right? This case that we're describing is probably a medium-sized dog, so the roots aren't all the way down to the ventral cortex. But in small dogs, the tooth roots and the crown are too big, hence the problem with crowding of the crowns and periodontal disease with smaller dogs, and the fact that those teeth are too big for their mouths. So with that, we often get bone loss that's significant starting at the marginal bone level where the periodontal disease is, working its way down, killing the tooth, then producing periapical lucencies, and or migrating down that bone or that tooth root bone interface, destroying the bone so that that tooth might even be a little bit mobile. Then that becomes an issue sometimes with fracture if the proper technique's not used. So many of our students that even come to our wet labs are apprehensive, and rightfully so, about extracting that tooth in particular if there's a lot of bone loss, and possibly that tooth in particular, even if there's no bone loss, as it's perceived as a difficult extraction. In reality, it's not that difficult. And if you have the proper training, and we provide that with our wet labs, we've got those coming up in June. You can find those at veterinarydentistry.net. Just look at my name down there and you'll see the link. You can register for the course in Atlanta at our new teaching center, brand new. We've only used it twice and it's incredible, in north of Atlanta in Sandy Springs. So I'd love to see you guys there. But anyway, again, that's one of those tangents I get off on. But with that being said, that tooth and the mandibular canine are the ones that fracture jaw structure most often during extractions, with situations where the practitioner may not be that comfortable with the extractions, and so those are often referred. And if you're not comfortable with that, I would recommend that you refer as well. But if you're comfortable, perfectly good technique that you've been taught, then certainly fine to do that. So that hopefully that answers your question. That's a long answer, Kristen, but that's the answer to that question. Sue Bowman, is the Denton Trail mention made with the Explorer? And yes, indeed it is. The Dental Explorer, which is on the other side usually of your periodontal probe, that is what's the term? Is scored in millimeters generally to let you measure periodontal pockets and attachment loss with gingival recession, and both or both combined. And is it done in the awake patient? No, it's done in the patient under anesthesia. You could possibly do it in the awake patient if you have a super good awake patient, but if that patient's head moves, that's a super sharp point. Therein lies the problem. So I would suggest that in all cases, with few exceptions, that you do it under general anesthesia. It's got to be evaluated anyway, and your radiographs are super important if there is something that is associated with an abrasion of a tooth. And so that determination, you need radiographs anyway because that tooth's been traumatized. So do it under anesthesia, Sue, would be the best way to answer that. Haley Arola. Haley, thanks for your question. Chevron affects something that affects more breeds than others. Is it common to see more on the maxillary or the mandibular teeth? And we generally see that in several places. One is the four central maxillary incisors, real common. The canine teeth, especially the maxillary canine, has a chevron effect, or it may have an effect from superimposition of the nasal cavity over the apex, which may look like a huge chevron effect or a huge lucency. So you have to be really discerning in order to make that call on the maxillary canines. Mandibular canines may have some of that, but usually not. Those, if you see a lucency, you want to look at the other side on those for sure, on the apex of the mandibular canines. And then the other place that you'll see those is the mandibular first and second molar, more common in the mandibular first molar, I think, than most teeth. You always want to compare that to the other side as well and make sure that your views are both parallel, which is a little easier to do. If you're comparing canine to canine in the maxilla, a little bit more difficult because you have to have pretty much the same angle of the tube head in order to compare really accurately, but you'll get a general idea. And if there's any question, then you either can have somebody consult with you on that radiograph after the patient wakes up. You don't want to assume that it's an extraction unless you know for sure. Certainly training in radiographic interpretation will help. We've got an online course for that at that URL that I mentioned before. 5 hours of just radiographic interpretation. So those things and the experience will help you make those determinations on that. So thanks, Haley, for that question. So let's go down to the next question. Michelle Pang, dental composites recommended to restore defects, seal dental tubules, and protect the underlying tooth structure. How long does it last, assuming normal everyday mastication? So if you have composite on there, excuse me, and you have a bonding agent under there, which is definitely what you want to do. The dentin bonds to that in the connective tissue of the dentin, in the tubules and in the matrix, and that's pretty much a permanent thing. The composite could get knocked off, certainly. And so if you're using composite, which very few people listening today are, there are not very many people who are using composite. They might be bonding, but we teach that in the advanced course. So if you're not doing that, that's where you get that information. But if you are looking to how long it lasts, if you're just bonding a minor defect in the dentin, that's going to last until tertiary dentin comes in and replaces that, or it's essentially forever. You want to monitor that tooth, because if you've got that insult into dentin and you're looking at it day one, let's say it comes in Monday, you don't know when that occurred. So it might have occurred 2 months ago, and we haven't had chances for the bacteria to get into that dentin, kill the pulp, and show radiographic changes as a subsequent result. So you always want to check that down the road a couple months after that, and make sure that you're up to 6 months after that or so, to make sure that there's no changes. If the patient's older, you probably want to go a year, because the canal is smaller and the changes are much more slowly to develop. So those are kind of the guidelines that you'd use for that. And mastication is not going to alter that for the most part. So good question there. Eric Yeager, totally a business question, more than a healthcare question. Do you think it's financially justifiable to learn restoration work in general practice? And I think it's super common to find it. And we get a lot of questions in courses about restorations and bonding. And it's not that super difficult to learn bonding. You want to know the basic principles of cavity preparation and the physiology of bonding to make determinations based on that knowledge. So that's a course in itself. Again, we teach that in the advanced course. You've had to have our level 1 and level 2 courses, or the equivalent. Level 2 is our weekend wet labs, which we're doing in June again in about 30 days. So we'd love to have you guys. There's a few spots left in that if you're interested in that. And this is actually the dates for that. Forgot I had that slide in there. So let me go to the slides and get off of my talking head there. So these are your instructors. Javier is my resident and helps me here in Atlanta. Dr. Jody Reed is a veterinary dental practitioner, as is Javier. And Javier's real close to boarding. Javier Fuentes, and both phenomenal oral surgeons, and they both do all of the procedures that we're talking about, and they help me teach the advanced course along with my staff. So it's a great experience that QR code there is a QR code. If you want to take your phone and scan that off of that slide, that'll take you to the advanced course, and you'll be able to register for that if you've had the courses that we've taught or the equivalent of a really intense surgical extraction wet lab like I'm referring to. So great question. Hope I answered that, Eric. It is indeed justifiable to learn that, and you just need to invest the time to get that kind of training. So Monique has a question. With a tooth that has only a root fracture, would there ever be a time where the tooth could stay? And that's a great question. And yes, indeed, a lot of times, and maybe more often than not, that tooth can stay. If you've got a tooth that is undergoing resorption around a fracture, but it's under the bone and there's no periodontal changes there, then that is probably never going to be a problem. So that root fracture under the bone level with no perio care or no perio involvement, it does not require extraction as long as there's no lucency there. If there is a lucency present, then with that lucency, you want to make sure that it is indeed a lucency and not a chevron sign. With a case where you have radiographic changes, like the one you're looking at if you're live and the one I'll describe if you're watching this on the pod or listening to this on the podcast, we've got an enlarged periodontal ligament space around the root segment, which means it's dislodged from the bone, and or it has periodontal disease associated with it, destroying the bone adjacent to it. In either case, that tooth crown is probably mobile, and so that would be another indication, along with what it looks like radiographically and what it probes as when you probe it, in order to make a determination that that needs to be extracted. So radiographically, if you can see that there's marginal bone to fracture communication, so where the tooth root and the bone are supposed to be, and where the fracture is, there's open space in the radiograph, and or you have mobility of that crown. Those are indications where not only the crown needs to be taken off, but that tooth root needs to be extracted, whether it has a lucency or not, because it's probably going to establish a lucency given enough time if there's periodontal involvement. If there's a lucency in addition to that, then that means the tooth is already dead and the bacteria have gotten out, destroyed the bone around the root tip. And so that's certainly a definite indication for extraction of that segment. So I hope that answers your question, and we'll go to the next question. And thanks for that, Monique. And Vicky Panos, I'm not completely clear on the indications for extraction based on the x-rays. Is it the pulp cavity that seems compromised apically? And Vico, we're also doing this as a podcast, so let me describe what you're talking to and show the people in the workshop exactly what we're talking about as far as the x-ray goes. So this is what Vico's talking about. We've got a fourth premolar. The distal root has maybe a 2 millimeter decrease in bone density around the apex of that distal root, and the arrow is pointing to that. So if you're listening, you can appreciate what that lucency looks like. And so if that lucency is there, back to the question, is there ever a time where that tooth can stay? I'm sorry, Vico, if the pulp cavity is compromised apically, is extraction indicated? And the answer to that is it may be, and usually is, but the other alternative is root canal. So you never know. It may be that the client wants to pursue saving that tooth. And if that lucency is just not horrendous and it's not associated with a suborbital fistula, then with treatment, removing the disease pulp, sterilizing the canal, which is essentially the first phases of a root canal therapy or root canal treatment, and then placing a sterile material in the canal and then sealing that eliminates the thorn in the abscess, right? When you think about thorns in abscesses or foreign bodies in abscesses, if you remove the thorn, the abscess is exposed and drains, and then it resolves with or without antibiotics in most cases. So same thing here. You remove the source of the infection and the tooth stays where it's sterile. The sterile material is not compromised. The tooth or the bone around the tooth root starts to resolve or remains the same and never progresses, and there's no dissolution of the apex of the root over time, which we follow radiographically. Then that's a perfectly good alternative. If the client does not want to do that, if you have a periapical lucency, there is no instance where you would leave that. You always want to extract a tooth if the owner does not opt for root canal, if there is a periapical lucency around the tooth root. So nice question there. So let's transition to our next question here before we close this case. And this is a good question that everybody needs to know the answer to, because we do this a lot. So Kimberly asked about diamond football or diamond burrs. And if we only have one, what do we need? And the diamond football burr would be the one to go. That's mainly the larger one that's a canine football burr. Cindy asked a similar question, wondering what size of football burrs that you should have and how you decide on cross-cut burrs. And in all these cases, and with the equipment, instruments, courses, whatever, you can also go to drbrettspets.com, and that's got everything you need. It's not a hard website to navigate like all the other dental websites that you have to search through hundreds of burrs. We've got everything on one page that we recommend, that we use in our practice and that we recommend our students use. We've got some burrs that we use in our practice that we don't recommend for general practice just because you don't use them that much. But the ones we do have are on here. So the feline cross or the feline. So thanks for listening to this episode. We'll see you next week. And if you haven't already, please register for that free live new training July 17th. We're expecting around 600 to 1,000 people to be there live on that date. So don't miss out. IVDI/July will get you into that course. And we'll see you guys next week. Take care.